I'm delighted again to have my friend Dr. Stephanie Goodwin back to join us. Those of you who came to Steph's last session know how good it was. She was excellent. And she enlightened us with lots of details and specifics that helped us understand female health and our hormones. And it was interesting for me because, like, many of us know the basics about our health. Many of us know like the basic things that we have to do, but I feel like it's like the real details that make the difference. And as Steph calls them, the light bulb moments where you kind of go, gosh, yes, I didn't know that. That's really important. So really happy that Steph is with us today. She, as you know, those of you who joined last time, is a specialist in women's health, but has also been a GP for over 25 years. And very passionate, it's a very passionate woman about empowering her patients with the right information so that they can prevent the onset of disease. So today she's joining us to talk about the major diseases that we deal with in the Western world as we get older and what we can do to prevent them and stay strong and healthy. As usual, please feel free to put your questions and comments in chat as we go through our talk today, and we'll address those as we go along. And if you can please leave yourselves on mute, that would be very much appreciated, just to avoid any background noise. So Steph, hello, how are you?
Very well, Stella, I'm very well. It's a nice sunny morning here in southwest London. So yeah, it's I'm feeling good. Lockdown's semi-changed, but it hasn't really made that much difference to me, to be honest. Because I've still been going into the office, but yeah, and I'm feeling good. It's nearly Christmas and I've got my first Christmas present, so I'm feeling quite happy.
Oh, very good, very nice. I just want everyone shift around because I want everyone to see your microphone. I just want to remind those of you who were present last time, and those of you who weren't. Steph is not only, oh, and the piano. Steph,
all happening over there.
Oh, all happening over in that corner. Steph is not only an excellent doctor, but she is a musician and she's a jazz singer and a pianist. And I always love telling people that, just to show your zest for life. And
and yours, Stella. I've seen you at your piano as well.
Yes, my piano. I'm missing my piano in Cyprus. So, yeah, I think my parents are dreading me buying some electric kind of thing and driving them crazy here, but yeah, hey, you know, you never know. So so today we'll be talking about the big ones, Steph, like heart disease, diabetes, stroke, because to me it seems like that they often get overshadowed by cancer. Like there's a lot of talk about cancer, and unfortunately, you know, cancer is an awful illness and so many people get affected by it, but heart disease is still the biggest cause of death, right? Especially
absolutely. Yeah, and I think, you know, we all, I mean, I certainly would always think that heart disease was something that men and old people suffered from, but it's not actually. Women in their 50s, it's the main cause of death. So with every decade from the age of 40, you're more likely to die from heart disease than you are from breast cancer. So it's the main cause of death in men and women until you get into your 80s, and then the main cause of death is Alzheimer's or dementia, which in a way is it's another type of cardiovascular disease often. So the cardiovascular system, so the heart and the blood vessels, is a very, very serious cause of medical conditions from the age of 40 onwards.
Yeah, and I know you're very keen on pushing that message forward because people don't know about that. So let's start talking about it in detail. So let's talk about the risk factors for heart disease. Let's go through that first.
So the main risk factors are gender and age. So being a man is a slightly higher risk, and age over the age of 50. So with every year that goes up, regardless of anything else, your risk of having a heart attack or a stroke increases. So age and gender, obviously we can't do anything about that. Smoking, a big risk factor, because smoking makes your arteries fur up, it can make the blood more sticky. So again, you're much more likely to have a heart attack or a stroke. Being overweight, which can cause all sorts of metabolic problems, so diabetes and high blood pressure. So being overweight or obese, a major risk factor. A family history. So when you talk to people, if you have a family history of premature heart disease, which is before the age of 60, then your risk is significantly higher. So it's really important. I often ask patients about their family history and they don't really know. You might know about your parents, but sometimes when you dig a bit deeper, you see that the family history is very widespread of early heart disease. Sedentary lifestyle, so lack of exercise is another one. High cholesterol levels, which you might not know if you never have your bloods taken. So I think what's important to know about heart disease is that nearly all of the risk factors for it are identifiable and treatable or preventable. So the only things we can't change are our age and generally speaking our gender, but everything else, and family history, but everything else is modifiable. And the other one is alcohol, which is very pro-inflammatory. And so that's another strong risk factor for heart disease and all the other chronic conditions.
Yeah, can we get into those in a little bit of detail? So let's talk about weight, because there's so many different kind of positions on what overweight and obesity is.
Yeah.
And there's people who say, well, BMI is rubbish and other things are more important. What can you shed some light on that for us, please? I mean, what is a healthy weight, and at what point? Because some people can also become a bit obsessed with their weight, and it's the other way.
I know. I mean, I think it's with all of this, it's about balance, and the main risk factor when we talk about weight is actually visceral fat, and visceral fat is the fat around your internal organs. So it's the fat around your waist. So, you might get people who have a high BMI, which is a ratio of your height to your weight. But, I've got patients, men and women, who are tall and they're muscular. They might be rugby players or sports people. And so their weight is high, but their muscle mass is high and their body fat is low. So if you just use BMI, the height to weight ratio, then people like that might come out as obese. But if you just measure around your waist, that gives you the best indicator. And actually you can buy scales. I've got some in my office, which were very expensive, which measure your muscle mass and your body fat percent and your visceral fat. But actually I noticed online somewhere, you can buy scales that will measure that for you for about 70 quid. So you don't need to spend a fortune. But the key thing is it's more about your shape. So it's once you start carrying weight a lot around your waist, that's the high risk. And so that's the visceral fat. And, I normally say to patients, really, all we need to do generally is eat less. The vast majority of people who are overweight just eat too much. So really just reduce the quantity that you eat and reduce the amount of alcohol, because alcohol causes, we've all seen men and women with beer bellies. That's all visceral fat from alcohol consumption.
Yeah.
So I would say to people, don't make life too complicated and start doing lots of faddy diets, but just eat less, have a smaller plate. And as soon as you feel 80% full is the guideline, is then you stop eating. So, I like to keep it simple, because then people can follow rules and make it part of their lifestyle without being on a diet. Sure. So yeah, looking at visceral fat is the key thing.
Right, so it is that belly fat. It's interesting as you say this, because since I've been here, I've learned about my families, my grandparents and great grandparents, and they have heart disease. It's very prevalent in my family, and it's so interesting because my family all have these very skinny chicken legs, as I call them, and big bellies. And so, but that makes a lot of sense, so it's made me very much aware of what I need to do because I'm very prone to put on weight around my belly versus other parts of my body. So it's obviously hereditary, and it's something I need to be aware of. and you're absolutely right about cutting back the volume of food, because you become, but you know, it's true, like the more you eat, the more you want to eat, and it's almost like you stretch your stomach, and if you can reduce that a little bit, you feel satisfied. With
also, if you eat more slowly,
yeah,
then the message that you're full has a chance to get to your brain before you've emptied the whole plate. And I think, you know, what I see in families that I look after is that, you know, if you've got a big strapping bloke in the family and kids who are big anyway, you feed them more because they look as if they need more. And actually what's happening is you're just feeding everybody too much. So I think it's really easy to get into those bad habits. The hardest thing is to try and break them, but really and truly, that is what the vast majority of people need to do. And also with women in the menopause, after the menopause, women's body fat moves from peripherally to around the waist. And that's why women's heart, one of the reasons why the incidence of heart disease in women goes up a lot after the menopause, because estrogen protects you against that redistribution of body fat.
So the alert is really, if you start putting a lot of weight around your waist, to start taking that very seriously. And I just want to touch a little bit on alcohol as well, because it's something I've noticed again since I've spent a number of weeks here in Cyprus. It isn't a major part of their life. Alcohol is part of, you know, food. You have a glass of wine with your food, and that's it. And in the UK, it's such a major part of our lives, you know, and that we feel that we can't get by without having a glass of wine every day. Or, you know, if we're stressed, the first thing we reach is for a glass of wine, or other things, you know, other forms of alcohol. And it's just, again, a shift in thinking around that. I mean, what's your position? Because again, you know, there are these medical guidelines around, you can have 14 units a day, but that's actually 2 glasses a day. And you know, I know for a fact that you don't drink very much, you know, and so what's your position personally, rather than as someone who's a representative of
well, I mean, the reason I don't really drink is because I get migraine.
Okay. So
you know, it's just it just doesn't work for me. I'm all right if I'm drinking very, very expensive wine. I'm very particular about. There's a few people who I will allow to buy me drink, but generally speaking, you know, unless it's at least 30 quid a bottle, I will get a headache.
I love it.
It's very expensive going out for drinks for me. So that's just my personal. I mean, I like, you know, I like a nice glass of wine. I currently can't taste it properly because of post-coronavirus anyway, so that's even less of an incentive. But I think it's interesting because I've got some lovely patients who I look after who are from South America. They're great. They're really not young men. They're in their 20s, and they've said to me, God, you know, they work in advertising, and they think it's bizarre the way that people drink here. They're like, gee, what's wrong with you people? You just go out and you just drink for the sake of it. And they like to drink fine drinks with their meals. So I think we've just lost, maybe we never had it, but in our culture, alcohol is not a treat. It's, you know, you might just drink wine because you're feeling a bit thirsty. And, you know, alcohol is not good for you. It's not good for you. And since I qualified, which is a very long time ago, the upper limit of what you should drink has dropped dramatically. So for men, it was 30 units, then it was 25 units. Now, the recommended upper limit of units for men is the same as women, 14 units per week. And 14 units, I mean, for me, that's a lot. I'd never drink that. But I can see for some people that is not much, because a unit is a small glass of wine. So it doesn't take long to get through that if you drink regularly. And it's not a bad idea, if you do like to have a drink, to get a unit measurer, because otherwise, before you know it, you've had a lot more alcohol than you think. And I've certainly had many patients over the years who are not really drinking excessively, but gee, they've run into all sorts of problems with abnormal liver function and, you know, this central obesity and other medical conditions. when they're really not drinking very much at all. It's pretty toxic stuff. And I think it should just be really used in moderation and as a nice accompaniment to nice food. And not just to go and sit in the pub and drink wine on its own. To me, that I would never do that, but that's just me.
And it's thank you for that. Thank you for making that point, because it has become culturally such a and it is a treat. It should be a treat, rather than that. And it's made me readdress that once I'm here. I'm not a big drinker either, but here seeing how they also think that, like, oh, you people are weird, you just drink for the sake of drinking. Like, it's almost like we're numbing everything through drinking. We're numbing how we feel, or we have to go out on a Friday night and get plastered because our week has been so bad. But what does that tell you about our lives? So it's just become anyway. We'll move on from alcohol. I wanted to touch on that because it's an important subject.
The other thing,
and people normalize it. People normalize having 3 glasses of wine a night, and they think it's okay. And
it's not.
It isn't.
The other thing I would just say is that people feel that you have to apologize if you're not having a drink. You have to explain why. So people will say to me, "God, are you not drinking?" It's boring saying, "Well, I get migraine, blah blah." So now my friends know that I don't. Occasionally I will drink, but generally I don't. So now, but some people I'm viewed of as a bit of a freak. Now I'm too old for them to think that I might be pregnant, but previously that might have been the case. But you do have to come up with a reason. I'm on antibiotics. I've got this. I would just say I don't want to have a drink. I'm going to have rhubarb cordial, which is my favorite tipple.
I like it. Okay, let's move on to the kind of technicalities of heart disease. Let's tell us what exactly is a heart attack. So people are aware of all of this stuff.
Yeah, so I think it's important to know what things mean, because these are words that are thrown around and actually we don't know what they mean. So our heart is basically a muscle that contracts, and muscles, like everywhere in our body, require a blood supply. So if you don't get a blood supply to your muscle, you get pain in your muscle, just like you get a cramp. So the heart is surrounded by arteries all the way around it to give it good supply, 360 degrees. And those arteries can get blocked up by cholesterol. And if your arteries get blocked up, then there is insufficient blood supply. And if there's insufficient blood supply to a muscle, it gets damaged. So when people have a heart attack, what happens is one of the arteries gets blocked up, and it causes the blood supply to a particular bit of the heart to stop completely. So the blood supply, each artery supplies a proportion of the heart. If there's no blood supply to that muscle, it dies. So that bit of heart stops working, and that's what's called a heart attack. If you get a big clot that supplies a big piece of heart muscle, then that's when people drop down dead with a sudden heart attack. The other thing that can happen sometimes is your heart can go into a very irregular rhythm. And that's when people drop down suddenly, apparently dead. And when we use defibrillators, which are all over the place, you put those on people's chests, you give them an electric shock effectively. And that abnormal electrical activity where the heart is doing this, fibrillating, you shock it, and then it goes back into normal rhythm. So that's why when people look like they're dead and then they're suddenly revived, it's normally because their heart has been fluttering and you manage to revive them with this defibrillator. So just a note, actually, while I'm thinking about it, really good idea to do some basic first aid training, which I have to do every year as part of my certification. But you can do this brilliant courses online, which will just show you if you're out on the street and someone drops down and there's a defibrillator in an old phone box, which is what happens around where I am, then you know what to do. So that's a heart attack. Angina is heart pain. And that angina is like cramp. So what happens is the blood supply to the heart is still working, but there's a partial blockage of the artery to the heart. So there's not enough oxygen getting through to the muscle. So you get pain like a cramp. And that's what gives the typical angina of pain in the center or on the left side of the chest. It can go into the neck, it can go down the arm. So that's the difference between a heart attack and angina.
Can angina cause a heart attack?
It can do. So yeah, I mean, if the blood supply to the heart remains poor because of poor circulation for long enough, then that piece of heart muscle will be damaged, and that is a heart attack.
Okay. And what can we do about this?
I mean, I think the key thing is to be aware of symptoms, because very often men and women have had these symptoms for a long time before they seek any advice. Sorry, that's just my delivery, but some
deal
with that for me. So yeah, the thing is to be aware of what symptoms you're getting. So in men, it's more typical, a sort of crushing chest pain, but it can feel like indigestion, which comes on when you're usually on exertion, but not always. So if you get any sort of chest pain or more breathless than you would be normally when you're exerting yourself, or pain in your arm or pain in your neck, then you need to seek advice. In women, it tends to be a bit more subtle. It's often not this typical, central or left-sided chest pain. It can just be breathlessness, or it might be lightheadedness on exertion or palpitations. So again, any of those even more subtle symptoms, go and get it checked out.
So if you're feeling breathless quite frequently, don't ignore it, in other words.
No, anything that changes, don't ignore it. And then, to reduce. And
how do you get it checked out? You go to your GP,
or you go to your GP. Yeah, I mean, look, if you have a severe episode, then you call 999. Sure. You need to go straight to hospital. If it's been going on for a little while and you're not too sure, you make an appointment and go and see your GP. They'll examine you, do an electrocardiogram, check your blood pressure. So these things are all very, very treatable, provided that you know that you've got it. But yeah, you must make contact with some medical service.
And that's quite ironic, really, isn't it? That heart disease is the major cause of death, yet it's so treatable.
Absolutely.
If you get it early, it's so treatable. And even if you don't get it early, it's treatable, right?
Yeah, I mean,
it's not like cancer that goes to certain stages. But for some reason, people aren't taking it seriously.
No. I think the assumption generally is that men get it, and generally that older, overweight men who smoke. I mean, yes, for sure, they're going to be the most high risk people. But anybody can be affected by this. Even if I've had slim, fit people, but if you've got a family history, then that should ring alert bells for you. So that's why it's important to know in your family who has had what, more so in your parents. But it's good to look back and see what's happened to people, because the clue is often in the history always.
Mm-hmm. There's a question in from Karen. What is atrial fibrillation?
Okay, so that's a really good question, Karen. So atrial fibrillation is a condition where part of the heart fibrillates, which means it does this, it beats irregularly. So atrial fibrillation is a very common condition, and it's one of the main causes of stroke. And the reason it causes stroke is because if your heart is fluttering away like that, it flicks off little bits of debris of cholesterol. And if you flick off a bit of cholesterol and it goes up the artery in your neck, then you may have a stroke. So many patients who end up urgently in hospital paralyzed with a stroke are then found to have atrial fibrillation. And it's easy to know if you've got it because you just feel your pulse, okay? And your pulse, you feel here on your wrist, and it should just be a regular, anything from 60 to 80 beats per minute. It should be very regular. Atrial fibrillation, your pulse rate is irregular. So you check it, it's like this. It's just never the same. And it might be like that all the time, and it might be like that intermittently. So some people just get bouts of atrial fibrillation. So again, it's a really, really important condition to diagnose because it can cause havoc, and it's very, very easy to treat.
Yeah, there's another question here. Actually, this is an interesting one as well, because I've heard this a lot about arrhythmic heartbeats, that you could be born with arrhythmic heartbeats. And Hilary, yeah. Is it less concerning if you're actually born with arrhythmia?
Yeah, I mean, look, many people, in fact, probably most people, will notice. I don't know if you do, Stella. I certainly do. I certainly get little episodes when my heart is irregular. Everybody will feel that for a few seconds. That's normal. And it's worse if you have coffee or red wine, or if you're dehydrated. They're also triggers for atrial fibrillation. But yeah, if you're born with some sort of arrhythmia, then that's just how you're wired. You know, the heart it's an electrical process. So if it's always been there, then that's different. If you suddenly develop atrial fibrillation, it may be because you've got underlying coronary artery disease. So you may have furring up of your arteries. You may have an overactive thyroid. That can also cause atrial fibrillation. So it's a sign that requires investigation, and it's easy. You can check for yourself. Just feel your pulse, or look at your Apple Watch, or any device.
Yeah, and so how do you treat it, and what kind of tests? I mean, talking about tests, there were some questions about cholesterol testing. How can we have tests done to kind of assess the risk around this?
For atrial fibrillation?
Generally heart
So the single most important thing is to have your blood pressure checked. Easy. You can buy a machine yourself for 20 quid. You can do it on your Apple Watch. You can go anywhere. So number one is get your blood pressure checked, because high blood pressure is an insidious condition that many people have and don't know, and it does a lot of damage. So we're aiming generally for a blood pressure of below 140 over 80. So the numbers mean the top number is the pressure in your arteries when your heart is contracted, and the bottom figure is the pressure in your arteries when your heart is relaxed. So the number one thing is get your get your blood pressure done. You can do that yourself. Cholesterol.
How should you check it, Steph?
If it's normal, then every 6 months.
Okay.
Yeah. Some people have really low blood pressure, but many people have high blood pressure and don't know about it. So I would say 6 monthly. If you've got a family history, if you're on certain medications, if you're overweight, then do it every 3 months. You can go into a chemist and do it. So, but generally speaking, every time you go to your GP practice, get it done. I sort of opportunistically check my patients' blood pressure. Cholesterol checks, that needs to be done by blood, can be done by your practice. Lots of practice nurses do blood tests. You can get these finger prick tests that you send off for, and some of those are actually really good. And especially now where it's better now, but where it's more difficult to get these routine screening tests done. So you can order things online, but many GP practices offer this to you when you're 40 and 50. They invite you for a health check where you get your blood pressure, your cholesterol, they check your urine for diabetes.
So is that available on the NHS?
Yes.
Okay. Yeah. People aren't aware of that.
No, I mean, you do get invited. I was invited when I was 50.
I wasn't invited.
Weren't you?
No. So have people here been invited?
Yes.
Yes. Okay. Maybe it's just me. Okay. Sorry. Carry on. Yeah.
Yeah. So really simple things can avert disaster. Blood pressure, weight, blood tests, urine testing for diabetes, but that's also, you can have that done by blood. Being aware of your family history, and if you become symptomatic. So get all those baseline things done, and then you're halfway there, really. Then you just need to speak to somebody.
Do you think then, I mean, over which age should you start having almost like annual checks about this? Should it be 40? Should it be 50?
I think 40.
Okay.
Because, yeah, I think 40, definitely 50.
Yeah.
Because, you know, by the time you get to 50, things can be well established.
Yes, yes, because again, on the continent, there's a lot of this annual checking going on.
Yeah.
Part of people's kind of health approach, or just how their medical systems work. Whereas in the UK, we are very, I mean, as wonderful as the NHS is, we are very reactive.
Yes.
And so we're not doing these preventative checks.
And to be honest, if we were a bit more proactive, then the reactive part of the healthcare system would be a lot less, because so many things could be prevented. But of course, then people have got to go. You know, the invitations, or it's often available, but then you have to go. So we have to take responsibility for our own well-being as well.
Absolutely. So let's move on and talk about stroke, because stroke is also a big one, right?
Yeah, strokes are terrible. I mean, of all the things, but you wouldn't want to have a stroke, because a stroke is where a little blood, it's either a blood clot or a bleed in the brain damages part of the brain, and then part of you becomes affected. So the typical thing we see is, you know, the patient where the face droops and one half of the body is completely paralyzed, or it can just affect your speech, so you can't speak, or it can affect another area where you can speak, but what you say doesn't make any sense. So the result of a stroke all depends on which bit of your brain is affected. But the main triggers for stroke are high blood pressure, completely avoidable; atrial fibrillation, completely treatable, and in some cases avoidable. So you've seen the advert where the person loses the face and the arm and so on, and it says call 999. I mean, with strokes, if you get to hospital quickly, they will scan your brain and see what's happened, and they will inject you with clot busting drugs, which can reverse the effect of what is a terrible life-changing event or death. So again, it's about the same risk factors, but that's what a stroke is. It's a little clot of something that's our cholesterol, usually, that's stuck on the artery wall, that comes loose because either your blood pressure is too high, or you've got atrial fibrillation where your heart is beating irregularly, and that flicks it off. It goes into your brain, and boom, that's a stroke.
Okay, there's a couple of questions. How is atrial fibrillation treated? It's
treated largely with drugs, very effective drugs. And if that doesn't work, then they do something called an ablation, which is, I think Tony Blair had it. It's where you put a catheter into the artery, it goes up into the heart, and basically they zap the area of the heart where the excess electrical activity is going on. So it's very treatable.
Is it short term, the treatment, like the drugs, or is it something that you have to continue taking?
Yeah, it's usually for life.
Okay.
Yeah.
Okay. Let's move on to diabetes. Actually, you talked to me about TIA. Let's talk about TIA.
Yeah. So TIA, these are very common. TIA is a transient ischemic attack, and it's a mini stroke. And what happens is a little piece, it's the same event as a stroke. So a little piece of clot goes into the brain, affects a certain part. So it might just affect your face. You get the symptoms, and within 24 hours, it's gone. So the clot goes, it causes a problem in the brain, and then it passes. So it's not a long-lasting event. But of course, that means you're at high risk of something else happening. If you've already had one TIA, you're much more likely to have another one. So, you know, people might sometimes have a TIA at home and not really know what it was, because they might just have felt their arm go a bit weak for a few hours, and then it's okay. And then you think, oh gosh, I wonder what that was. But you really need to get checked out to make sure what other underlying conditions might be going on. And
okay. There's another couple of questions here. How does an aortic aneurysm increase your risk of stroke?
So an aortic aneurysm, the aorta is the main blood vessel that comes out of the heart and supplies blood to everywhere in your body. An aneurysm is where the instead of it being a long, smooth tube, like so, it develops a balloon in it. So instead of it going straight across, it would go like that. That's an aneurysm. And aneurysms burst, and you can get aneurysms in your brain. And that's when people get a stroke that's a result of a bleed.
Okay. Let's talk a little bit more about cholesterol, because again, it's being aware of what your cholesterol levels are, which is really important, knowing when to start worrying about them and what we can do to bring them down, because you know, statins, everyone's got a different opinion on statins. I have a very strong opinion on statins. I'm sure you'll disagree with me, but statins are a way, of course, to bring them down, but is it possible to bring down cholesterol in other ways? So let's tackle that big subject.
Yeah, I mean, this is a big subject.
Yeah.
What I would say is that when you look at people's blood cholesterol levels, you need to look at that in conjunction with the whole patient. So, because the numbers are just one piece of the jigsaw, you've also got, does the patient smoke? What's the family history? Are they overweight? What's their blood pressure? So cholesterol can be very misleading. It's important, I'm not saying that, but I think just looking at it on its own is not the whole answer. But generally speaking, what we want to know is how much bad cholesterol do you have? Because there's good and bad. So what happens now with the laboratories, and we have risk scores that we can use for people. And I use one called the Q risk score. And Q risk, it's a calculation. And in that you put the patient's age and gender and blood pressure. And we look at what's the ratio of the total cholesterol to how much good cholesterol, or basically how much bad cholesterol have you have. And that enables you to work out a risk score. So if you have very low levels of good cholesterol and high levels of bad cholesterol, then your arteries are more likely to fur up. So just knowing the total, because your cholesterol might be 6.5, which on its own is a bit too high. But if 50% of that is protective cholesterol, then it's not as significant. So whenever you have cholesterol levels done, you need to know what the good and the bad is, because that gives you a much bigger, fuller picture. And, you know, again, you could drive yourself doolally removing all fat from your diet. You don't need to do that. It's about eating a balanced diet. I eat butter because margarine's much worse for you. It's got loads of trans fats in. I eat cheese and I eat cream, not very often. And, you know, but I also eat food that's good for me. And, you know, I don't drink too much and I'm not overweight and so on. So whenever you're looking at cholesterol, you have to know how much of the good, how much of the bad, and what are your other risk factors. But it's definitely worth having the levels checked, and your GP will do that for you. Okay,
but there are ways of bringing it down naturally rather than being put on statins, assuming that you're not in a big high risk.
Yeah, I mean, look, if you're in a high risk group, and we do this Q risk 3 score. If you're in a high risk group, then statins, what they do, if you've got a lot of cholesterol furring up your arteries, the effect of statins is to seal over it's called plaque, which is gunge for want of a better word. So what the statins do is they create a seal around plaque so that it doesn't move, because it's when plaque moves that you have a heart attack or a stroke. So if you're in a high risk group, statins are so effective. And they're also effective in people, even if you don't have high cholesterol levels. So even in those people, it reduces your risk of having a heart attack or a stroke. So I always, again, you know, it's like with HRT. you get the information, you do a risk assessment, and then you decide with the patient what's the best course of action. But certainly if your cholesterol levels are high and you're overweight and you're not exercising and you go away and you change your lifestyle, your cholesterol levels will come back down. But inherently we have genetically predisposed cholesterol levels, and sometimes in spite of our best intentions, they don't change very much.
Yeah.
So yeah, I think it has to be looked at as a look at the whole patient and not just at the numbers.
Yeah, I think absolutely. You're the expert, of course, on all of this. I'm going to get into an argument with you on statins and the doctor on statins, but there is sometimes the what's the word I'm looking for? The disposition or predisposition to prescribe statins, when maybe they shouldn't be prescribed. It's an easy one, and some doctors do that. I've seen that very much in my family, and it isn't always necessary. So I think again it comes back to understanding yourself and taking personal responsibility for your life and changing your lifestyle. I mean, Jane's made a good comment here. She her partner had amyloid angiopathy. I don't know what that means, but it leads to the brain. But the single most important factor to avoid stress on the brain: keep your blood pressure normal, anger management, stress management. You see, there's all these things that can affect that, rather than just being given a drug to do that, unless you're in a critical position, of course.
Yeah, sure. No, I mean, that's why I think that's why it's not just numbers. It's about who is the person sitting in front of you and what is their individual risk profile. And that's always many factors that all need looking at.
Yeah, that's why you're an amazing doctor, Steph. I feel like I want to cover diabetes, but we don't have enough time. So maybe we can do that as a separate session, because we've really got into this in detail, and it's an important enough session. It's an important enough subject to talk about, because there's different views around reversing diabetes and drugs around diabetes and through diet and all of this kind of stuff. So there is one question from Brianna: what are the dangers of statins?
So I don't think, I wouldn't call them dangers, but the most commonly reported side effects is muscle pain. So that's the most commonly, that's the most commonly reported side effect. But still, it's not that often. And if patients do report that, then there are choices of lots of different statins that you can use. So if one doesn't agree with you and you are in a high risk category, then there are loads more different ones that you can choose. And sometimes patients who take statins, if they are getting muscle pain, then if you take coenzyme Q10, which is an enzyme that you can just buy it over the counter, that can be really helpful for any muscle discomfort. But normally it doesn't happen very often. And for me, if it does with patients, we find an alternative. And if we can't find an alternative, then we don't. So, or if the patient's unhappy, then we don't do it. But generally speaking, if they're in a high enough risk category, then there are plenty of alternatives, and we almost always find one.
Sure. There was another question here from Lisa about can high homocysteine be an indicator of heart issues going forward?
Yeah, so homocysteine is a protein in the blood, which it's variable. I mean, some people say high homocysteine is a risk factor and some don't. It's not very often tested. It's quite an expensive test. You might only get that done if you were going to a specialist clinic for heart disease and so on. But you can bring homocysteine down by taking folic acid, a small dose. So if you take a multivitamin that's got some folic acid in it, then that's good for prevention of lots of things. So a little bit of folic acid in your diet or in a supplement is helpful.
That's really good advice. So yeah, Lisa, take loads of questions coming in. Folic acid. What about triglycerides as a risk factor?
So triglyceride is another fat in the blood, and yeah, triglyceride is another marker of a risk for heart disease. So if you're getting your bloods done, if your triglyceride level is a bit high, then we would get patients to come back and do the sample fasted, because triglyceride, if I've just sat down and had, a bacon sandwich, which I confess I did have for my breakfast today, and then I check my bloods, then my triglyceride level will be high. If I do my triglyceride level in 3 hours time, it will be normal again. So, but triglyceride is an independent marker for your risk of heart disease. Also, if you've got very high triglyceride levels, it can cause pancreatitis, which is a nasty condition. So if your level is high, it should be repeated with you having fasted, which means nothing to eat or drink for about 6 hours, or a drink, but not with milk in it.
Okay, and then you get a more accurate reading, I guess.
Accurate, yeah.
And then if it's high, what do? You have to just change lifestyle again. It's lifestyle.
Lifestyle. Often it's caused by too much alcohol or people being overweight. So you would do lifestyle. If it's still too high, then you would need to use medication for it.
So the main message here is change your lifestyle first, and then if it becomes, if it's still not changing, then we have to move to medication.
Yeah. If you can't do it with lifestyle, then move up the ladder.
Yeah. Odil's asking about vitamins. What do you take as you've got?
I take vitamin D. I take omega-3 when I remember, because it's quite hard to swallow because the capsules are really big. And I dip in and out of magnesium. I don't take a multivitamin. Sometimes I do. Really, throughout the coronavirus time, I was taking just vitamin D and probiotics. I think I was taking omega-3 during COVID. But, if you eat a healthy, balanced diet with lots of green leafy vegetables, then generally you're getting what you need.
Yeah. Flaxseed, Odile, is a superfood. It has all of those things in it. So omegas and magnesium. Yeah. So I add flaxseed to my porridge or to anything, yogurt, whatever, every day. So it's a good one. Okay. There's obviously people want to hear about osteoarthritis. But we just cover that a little bit now, and then we can cover it also next time. Let's talk about osteoarthritis briefly.
So osteoarthritis is wear and tear. Okay, so there are different types of arthritis. Well, there's two basically: osteoarthritis and rheumatoid. Rheumatoid, briefly, is an autoimmune condition where you get very inflamed joints, and you see people whose fingers are all bent, and it's a terrible, horrible condition. Osteoarthritis, look, we're all going to get a bit of that. Often it starts, I don't know about you, Stella, you get a bit in the base of your thumbs. That's where women often get it. Mine are a bit sore today, I don't know why, but anyway, so it's wear and tear. It's a natural part of aging. But there will be some joints where osteoarthritis is more marked than others. We see it a lot in hips and knees, which is why people have hip and knee replacements. So basically the joint just wears down, and then you end up with no cartilage, bone on bone, with very sore joints, excuse me. And then they get replaced in the back, because we see lots of wear and tear in the spine. And honestly, the key thing is make sure that you're not overweight, because certainly the patients I've been seeing, I think particularly over lockdown actually, who've been having lots of joint problems, almost all of them are overweight. If you're carrying extra, I don't know, even half a stone, you think how much that 6 kilos of potatoes or something is to carry. You think about putting that on your hips and your knees. So that's my number one thing. And I've said it to people for years: keep your weight down and your joints will be much better. It doesn't mean you won't get osteoarthritis at all, but it's definitely going to reduce the likelihood of that happening. So keep moving. That's the most important thing. I'm certainly, during the week when I'm working, I'm very sedentary. I sit down for 11 hours at a time. That is not a good, we're not designed to be like that. It's really important to keep moving. And it's important to keep your muscles strong because our muscles support our joints. So if your muscles are not doing much, then that puts more strain on your joints, which means you're more likely to get osteoarthritis. Avoiding, again, alcohol. It's very pro-inflammatory. That's not good for your joints. But my number one take-home message is make sure you're not overweight, but keep moving. That's two, I know, but.
Yeah, absolutely. I mean, I'm with you. I have those little aches, pains that, appear that I never used to have. But for me now, I do yoga more than I ever did when I was younger, and and it doesn't have to be yoga, but it for me that works. But it's just keeping your spine flexible, moving your spine and moving your joints, and even the qigong we did last week was perfect for that. Qigong, yoga. I mean, I walk a lot, but I find that sometimes it can make me stiffer. So so it's good to do that stretching, the releasing as well, to keep your joints supple. I'm
not a big fan necessarily of doing lots of jogging when you get even over 50, unless you're definitely built as a proper runner, because I just think all the strain, it goes up through your knees, it goes into your hips, it goes into your back. And I see the casualties of that, people in their 70s who are actually really fit, but whose knees, and it's the back is the problem, because hips and knees are easier to put right because you can just put a new joint in if you need to. Backs are much more difficult. If you end up with a lot of back wear and tear, it can be so hard to manage. So I think if you love jogging, okay, but if you can find something that you love equally, cycling or something else, then it's worth looking at a new sport that you might be able to start doing as you get towards 50. That's my own personal view, but I think that's because I've seen the casualties of that over the years.
Yeah, that's really valuable advice, because you've been, you see how people develop over the years, and you have long-term patients as well. It's really interesting, because what we do, this is the whole thing that was around the newsletter I sent out. What we do today we think is great, but how does that affect us moving forward? And once we do get over a certain age, we have to be aware of all of those things. So
I do think, your body will tell you if you're doing something that's not the right thing. Yeah. So you have to be aware and listen to the symptoms that you get.
Yeah. Wonderful. Thank you. Brilliant advice as always. We'll I'm sure have another session. And if you're willing to come back over the next number of weeks, because they're very it's all such great information, and just gives us those reminders and brings us that medical aspect too, because we're very much into holistic health, but you understand that too as a holistic, you take a holistic approach. And it's been brilliant. So thank you so much for being with us there. And thank you everyone for coming along again, and hope you enjoyed the session with Steph.